Good morning. Today, unlike last week, there is no rain. It's a beautiful morning in Northwest Arkansas. And let me tell you, I went to pick up our speaker today in Fayetteville downtown, and I'm like, what are all these students doing bright and early in the morning, taking up all the car spots? Well, there is a sale going on at 50% off for all the clothing that is UA branded. And so that is what was going on this morning. And the students are winding down the semester, but getting ready for the next one with all new clothing. So my name is Ranu Jung, as many of you may know, and you all know, but some of you who are on Zoom may not know. I am the director for the Institute for Integrative and Innovative Research, IQR. I'm an associate vice chancellor here. And this institute is a special institute. We are driven by a mission to pioneer solutions to wicked problems. And how do we do it? By a convergence research approach. And it's not just convergence of disciplines, but bringing together different sectors together: academics, industry, our community, our clinics, all the people together to take on really, really difficult problems. And we have picked our first initial grand challenge is integrative health. And that is what you eat, how you exercise, your mental health, how you give access to food, how you give access to health, and bringing all of that together and finding solutions to many, many different problems that are there. And then most importantly, finding ways to deploy those solutions so that we can actually have an impact. So 5 words define us: integrative, convergence, economic development, at scale, and social impact. So I think those of you who come here every week, by now you should have these learned by rote. But if you are new and you are on Zoom, welcome, and I hope you remember those. We are working to be the preeminent leaders in convergence research. So it's my huge pleasure to welcome Dr. Purnima Madhivanan. Dr. Madhivanan is an associate professor in health promotion science at the Mellon and Zuckerman College of Public Health at the University of Arizona. She's the director of the Public Health Research Institute of India and director of the Global Health Equity Scholars Training Program. She has a medical degree, she has an MPH, but I think most importantly, she has a passion and a determination to make a difference, especially for women's health. And that passion has driven her over decades of her career, and not just doing something inside in an academic setting, but actually making a difference. So I had the pleasure of first finding out about Purnima when I was at Florida International University, and I had a biomedical engineering faculty member in our department who was doing some technology development to try to deploy. I said, there is a professor in public health. I think you need to talk to her. And then, I think they had that faculty member from BME ended up going to India in this major program. And I'm sure Purnima is going to tell us all about that. But then when we were picking people for our speaker series here, and we were talking about how are we going to, who are we inviting, who's going to bring the impact story, and right away, Purnima's, in my mind, I thought, she's the one we need to bring here to think about how we talk about impact, how do we talk about deployment, how do we talk about engagement, this whole convergence approach, and she brings that to the table. So without much delay, I'm going to invite you, learn about how you can make an impact on all people's disadvantaged, but not necessarily disadvantaged, because we who are part of this whole ecosystem, we are all knit together. And what she's doing is so impactful. So welcome. Thank you.
Good morning, everybody. I want to first thank Ranu for inviting me here and seeing all the fun stuff that you're all doing. It seems to be like you guys are going to be the disruptors on the scene. And I'm really looking forward to seeing all the things that you all are going to do. But before I start my presentation, I want to first acknowledge my elders, my ancestors, my teachers, and my mentors, without whom I would not be here today. So having said that, I do not have any disclosures. Ranu has already told you about me, so I'm going to skip that. But I think it's very important that people understand why we do what we do. So I want to kind of give you my positionality of why I do what I do. I was born in a village and I was raised in a metropolitan city by a single mom who had eighth grade education because my father, who was in the Indian Air Force, he passed away as soon as we landed at this new station. And my mom had to make a decision whether she wanted to take us back to the village or stay in the city and educate us. So she decided to stay in the city to educate us. So I was educated in an army school. And then I'm the first person in my family to go abroad for education. And I came to the United States to get my master's in public health and a PhD in epidemiology. I speak 5 languages. I've lived around the world. I self-identify as a cisgender, heterosexual, mother of a differently able young woman. Shout out to my daughter, Pavlina. And I am influenced by the representation of women in science, global health, and in leadership. This is what drives me every day to wake up and do what I do. I want you to take a close look at this picture. This is a typical scene of a village from where my mother comes from. And this is a typical scene of a village where 60% of folks in India live. Now, the closest place from a place like this would be about an hour, 2 hours before they can get to a healthcare facility. So that is the scenario in which I do my work. So I'm going to talk to you a little bit about healthcare and HIV, which is where I started my career. Challenges in rural health programs. What are some of the strategies to overcome these challenges, and where do we go from here? Been hearing a lot about all the fun stuff that's happening and also all the fun stuff that is not happening. So why do some health innovations fail while others succeed, right? Everybody has the same idea. We all want to change the world. Well, the World Health Program, the SKY program, which was in rural Bihar, they spent $23 million to improve primary health care for children, and they had no impact on healthcare utilization or bringing down the infant mortality or morbidity. $23 million. The government of India, this is very close to my heart because I was in the depth of this work when this happened. The government of India shut down the HPV vaccination demonstration program after massive protests by human rights advocates. Because of the 23,000 young girls who were vaccinated, there were 7 deaths. But those deaths were not associated with the vaccination. It was a diarrheal death, fever, snake bite. But it was among the vaccinated group, among a very disadvantaged poor community. So there were issues, rightly so. Vietnam spent a lot of money to bring down the vertical transmission, means parent to child transmission of HIV during about a decade ago. And they could not reach success. Why is that? Right? These are all multi-million-dollar projects. So there's no dearth of money, but they all fail. But some did succeed. The Narayana Health is a private, for-profit cardiac hospital based in Bangalore, and they decided to make heart care available to even the poorest families in India. They offer heart surgeries for $2,000, which can cost around $100,000 in the United States. Yet, they make a profit. Their valuation right now is over $1 billion. Another one, Arvind Eye Hospital. All of us in India know about this. They've been using mobile health clinics to offer free and subsidized eye surgery for thousands of rural patients at deeply subsidized rates. But they are not running in loss. They have surplus. Now, why is that? So why is it that the last three programs I told you failed, but these two have succeeded? They've all had the same amount of investment in money and effort. So a lot of people have thought about this, and they've all come up with different reasons. Field said that we often don't fully appreciate the scope of the problem and the user's needs. Moore said it's about the context in which these interventions happen. Brett Hoover said you have to be reaching people at the right time, in the right place. And then Martin said, we simply don't know enough about systems because these are complex systems. Not that I want to quote Donald Rumsfeld. For those of you who haven't known more students, Donald Rumsfeld was the Secretary of Defense from 75 to 77 under Ford. And then again, he was under G.W. Bush or George Bush from 2001 to 2006. But I like what he said. He said, we don't know what we don't know. We know that little circle. We try to get to the middle circle. That's how far we go. No matter how much research we do, whatever we try to do, we never get to the outside circle, the unknown. And that's where the problems are. So for me, most of my work has been in low and middle income countries. And I'm always like surprised when something actually works. Where I work, very close to each other. Extremely different. You can't use the same language, you can't use the same approach, you can't use the same culture. Everything is different. Now, how do we know enough about both the communities that your intervention that you're going to talk about or you want to roll out is going to work in both of these communities? They're right next to each other. We have this one-size-fits-all approach, right? And Gates Foundation, when you go for funding, they say we want scale. Everything is about scale. But here, if you talk about scale, we're going to fail miserably. Much of my work has been in India. We are 1.4 billion people. We are the most populated country in the world. We have exceeded China. We speak 122 languages. We have newspapers in 87 languages, radio programs in 71, and movies in 15 of those languages. We are home to the largest Hindu population, the second largest Muslim population. We are also the originators of other major religions like Buddhism, Jainism, Sikhism, and you name it. We have one of the oldest caste systems, which even to this day matters in everything we do. We have an election going on right now in India, a major one. And caste plays a big role in who's going to vote for whom. And that's going to decide the next 10 years for us in India, what's going to happen. A little bit about maternal child health, because I've been hearing a lot about maternal child health issues right here. So I thought I'd give you a little bit of an example of where I was working. Maternal and infant mortality poses substantial challenges for global public health. And the WHO reports have, even most recent as 2020, have said the maternal mortality ratio is exceedingly high. We're talking about 223 maternal deaths. And Central and South Asia, which includes India, are the biggest contributors to this global maternal mortality. And we are at 129 per 100,000. And in 2020, India had the second highest maternal deaths. We were around 24,000 fatalities, second only after Nigeria. And we have similar issues with infant mortality. Challenges of why we have these issues, according to the United Nations, we don't have enough skilled birth attendants. The skilled birthing has only increased from 56% to 68% in 2012. And the India's neonatal mortality, which is the first 27 days or the first month after the baby is born, has declined by half. But we still are one of the top 10 countries in the world with highest infant mortality. Birthing in an institutional setting has been found to reduce the risk for infant death. And in order to promote institutional deliveries, the government of India established something called the National Rural Health Mission. And this was in 2005. Institutional births went up slightly. They went up from 39% to 47% in 2008. But in spite of that progress, with the National Rural Health Mission, which was a huge policy for India, a lot of money put into it, at least 1 in every 2 births continue to take place at home. And about half of all these births were being attended by traditional birth attendants or unskilled birth attendants. So who am I to talk about this? My journey started when I finished my medical school, and I was clueless what I wanted to do after I finished, because I didn't want to do the same thing everybody was doing, and medicine was boring for me. So I was trying to get rich very quickly. So my intention was get an MBA, find a company, or go to an industry, make some money. I was part of a running club, which was called Hash House Harriers. Runners with a drinking problem or drinkers with a running problem. You choose what you want to do. So at one of those sessions, one of my friends said, hey, there's a doctor here in Chennai. She's looking for another doctor to help her. And I was like, Chennai, one of the biggest metros in the world, in the country. Why would she need another doctor? There's no dearth of doctors in Chennai. She said, just go talk to her. I said, sure, what do I have to lose? I had a baby, I was getting sick, staying at home. I said, if I can get a break, a few hours, why not? So I met her and she said, I'm really looking for a doctor. And I was not sure what I was signing up for. My whole idea was I needed to escape home for a few hours. So I said, you find me a babysitter and I'll come and help you for a few hours. I had the most amazing babysitter, Hamsa. My God, I love that girl. Hamsa saved my sanity and my life because I was able to leave home, leave my baby with her, and go to this clinic. And it turns out this clinic was an HIV. And this was during the time when antiretrovirals were not available and patients were being thrown out of hospitals because of stigma, because hospitals didn't want to deal with HIV. And this woman who had met me, she was the person who discovered HIV in India among the sex workers in Kamatipura in Mumbai. And she was a professor of microbiology, Dr. Suniti Solomon, bless her soul. She's no longer there, but she has been one of the inspirations for me to do what I do today because I worked under her and I learned a lot. So she took a voluntary retirement from her academic position. She was a professor and head of a microbiology department, and she started this NGO to provide care for people who were being thrown out of hospitals. And that's what she got me into without me realizing what I was signing up for. So I would get the Hopkins manual for clinical management of HIV, and I would flip through it, and I learned my medicine, and I got my passion back for medicine. Had the only HIV women and children's clinic in the country. And because I could speak 5 languages, I had patients coming from all over India to see me. But what I found was most of the women I was seeing were in their late teens, early 20s, just gotten married, gotten pregnant, found out they were HIV. Or they were bringing their husbands in to get admitted because husband had AIDS, had all the opportunistic infections, so they were coming as caregivers. So when we would test them, the women had HIV. That's where I started. So I started with trying to prevent vertical transmission of HIV from a pregnant woman to the baby, trying to find a hospital that would allow us to deliver these babies. And we had to do it all incognito because other patients didn't have to know. So we had to make deals with the hospitals to allow us to bring up patient and get the delivery done. So that's where my journey on women's health started. And these other group of women, they really didn't need me because they were perfectly fine. Yes, they were HIV infected, but they didn't need a doctor. The problems they were having was being thrown out of their husband's house because the husband's family said, you bring bad luck, so my son died. Or they can't go back to their own mother's house because they have a marriageable child in their house or their sister or brother. So having an HIV infected person in the house, there's stigma, so nobody would marry their sister or brother. So these were the kind of issues I had to deal with. And medicine had not prepared me for that. Medicine teaches you how to find the bug and kill the bug. It doesn't even teach you how to take care of your body. It tells you, find a bug, that's the drug, kill it. That's why wellness is so important right now for us, to think beyond that model of finding a bug and killing a bug. So that led me to trying to understand prevention. How can I prevent these women from getting infected in the first place? And that's where my journey started about engaging communities. So India, preventing vertical transmission of HIV was one of the biggest problems. I'm talking about the time when I started. And we were one of the top 10 countries with the highest burden of pediatric HIV. And we were one of the largest sources of HIV infection among children, with almost 30,000 new infections each year. And most of the infections, most of the infections were happening in one of the states that I work in, which is called Karnataka. So while almost all of these infections can be prevented, only about 14% of the mothers were getting the medication that can prevent the baby from being protected from the virus. And that is because 27 million births happening each year, only 6 million of the women were being tested for HIV, 22%. Only 9% of the rural Indian women were receiving any testing for HIV in their current pregnancy. And 48% of the indigenous populations and 20% of the low caste Hindu women even attended hospitals. So you're not even going to reach them. So I got a grant. I got the International Leadership Award from Elizabeth Glaser Pediatric Foundation. And the reason I'm putting this out is because Elizabeth Glaser Pediatric Foundation gave me money. They said, we're going to give you money and you figure it out, because they'd seen my work, and that's why they have given me this award for HIV, International Leadership for HIV. And they said, we're going to give you money, you figure out how you want to solve this problem together. So my goal was to reduce vertical transmission of HIV by integrating antenatal care and HIV using mobile clinics. And that was the direction I was going in. And the World Health Organization in 2014 data had shown that antenatal care in rural communities was about 50% for one antenatal care visit and 10% for 4 antenatal care visits. So women were not getting antenatal care. Availability of skilled attendants was only about 20% in rural communities. And the National Family Health Survey in 2008 showed 38% of the women had an institutional delivery, and remaining deliveries were happening at home. A district level household survey was done in 2007, and they found being closer to a healthcare facility increased the probability of an institutional delivery. Makes sense. Social determinants, right? Each additional kilometer away from a healthcare facility decreased the probability of an institutional delivery by 4%. They were able to actually measure it. So there were large disparities in terms of antenatal care and skilled birth attendance, and they were all associated with economic factors or where the person stayed, geographical distance. In spite of everything that was happening, only about 20% of the women were getting tested for HIV. This was during the peak of the pandemic when India was one of the top countries. And only 3% of the antenatal care sites even offered HIV testing. So just so that you all know where I work, this is the state of Karnataka. And this is Bangalore. This is where I grew up. And for those of you who are not familiar with Bangalore, when you try to call your airlines or your credit card companies, we are the guys who answer your calls. We are the Silicon Valley for you guys because most of the engineers who are going to be coming here to work are all going to be my people. So you got to be nice to us. And I work in Mysore, which is southwest of Bangalore. And the reason I work in Mysore is 5 kilometers in any direction, you're in absolute rural areas, like the picture I just showed you where I started. So this is the sub-district of Mysore, and all those little blue lines are showing you the villages. So my work happens in the 144 villages outside of Mysore city. Because Mysore city has no dearth of doctors. So my objective was, how do you reach the unreachable? So a little more information about Mysore. Karnataka has some of the highest maternal mortality rates in South India. We have 144 deaths for every 100,000 live births. It's still lower than the national average of 190. And that time, the Millennium Development Goals had said we had to reach below 109 deaths by 2050. That was the Millennium Development Goals. Now we have the Sustainable Development Goals. But we were at 144. We had to come down from 144 to somewhere close to 109. That's an uphill task. There were a lot of barriers to do that. And one of the challenges was utilization of services during pregnancy, childbirth, and after childbirth, postpartum. And in 2005, 62% of all deliveries in Mysore were home-based. And they were mostly attended by untrained birth attendants. And 2/3 of the population of where I live and work are in rural areas. And we had little information about these unskilled birth attendants. So we wanted to try and understand who are these women who are delivering all of these women in these communities. And they have never been integrated into the healthcare system in India. In fact, they are considered a taboo. So they are not part of the system and they will never be a part of the system. And why is this such a challenge? Like I said, when in Mysore, in Karnataka, we have about 20% of our population is Muslim. We have people from all over the world come to Mysore to attend Dashera. We have the royalty still living in the palace. About 70% are Hindus. We have the second largest settlement of Tibetan refugees after Dharamshala when His Holy Highness Dalai Lama moved from Tibet to India. The second largest settlement is in Mysore. We have the Jains, and we have a very small percentage of Christians. So very diverse. Now, tell me what you see in this picture. Mother-daughter. Eh?
All the pictures so far, I've seen wires.
Yes.
Yeah, electricity and communication.
Yes. Yes. But do you also see the quality of the construction on the right side versus the left side? Do you notice that? That's the cast. Okay. So if I'm going into that community and setting up my clinic on this side, these guys are not allowed to come. And if I set up my clinic on that side, these guys will not come. And this happens in every community. In the public health system, the lowest in terms of the cascade of health clinics that we can have at a village level. And in this particular village, it also served as an Anganwadi center, which means a child care center for under 5-year-olds. I want to take you inside. That is where a woman gets delivered. And that is all she's going to have. So she has to bring her bedding, she has to bring everything with her to the clinic to get delivered. And after delivery, her family has to clean up the place before she goes back. What do we have? That young girl is the one manning that clinic. And they have instruments. Of course, they have instruments. Do you see those instruments? Do you see the rust on that instruments? Because nobody knows how to use them. They have it. The government has a checklist of every clinic has to have all of these things. So of course they have it. How do they get sterilized? They don't know how to use a sterilizer. The packaging is still sitting inside that sterilizer. It's laden with dust. So of course, we have everything in that clinic. So we can check it out and say, yes, this clinic has all the instruments, a sterilizer, can be a birthing facility. But will you go and give birth in that place? I wouldn't. Or hell, I wouldn't let any of the people I know go and give birth in that place. So our objective was integrated antenatal care and HIV because we didn't want people to go for antenatal care here, testing there, counseling for HIV there, and then getting the results here, and then coming back here. People are going to fall off the tracks. So our plan was one-stop shop. You go in there, you provide all the services and get out. So what we wanted to do was develop a cadre of healthcare workers to provide PMTCT services in rural Mysore. We wanted to map, train, and integrate the traditional birth attendants into these referral networks because you can't ignore them. If we are not able to provide a solution, you cannot just bring up a problem and say, oh, they are a problem. Okay, if they are a problem, do you have a solution? If you don't have a solution, don't talk, right? Easy to point fingers and say there are problems. Very difficult to come up with challenges. So these are the women who have the trust of the community. They know their communities better than you and I. So is there some way we can integrate them and see if we can kind of get them to help us in our mission instead of making them our enemies? And then to implement these mobile clinics. And then we wanted to describe the factors with where women are delivering and why. So we did this longitudinal evaluation of the feasibility and uptake of this integrated system. So we had 3 components for it to be successful. We wanted to assess, train the healthcare providers to provide services for women who don't have access. We wanted to have intensive engagement with the community. And then we wanted to have this medical care being delivered in their communities. So ours was an extensive 3-day program. So even before we go into this 3 days into the community, we were already doing prep work, getting permissions from all the main leaders and gatekeepers and all of that. But once we were in the community, it was a 3-day program. Instantly, we had failures. I can write a PhD on failures because I've had more failures than successes. And my CV for my failures will be twice or maybe 3 times longer than my CV right now. Okay? I am an expert with failures. Straight away. How easy was it? Mysore, Bangalore, in Mysore, by the way, we have 2 medical institutions. We pump out 300 doctors every year. In Mysore, forget about Bangalore. But we can't get a damn doctor to save our life, to provide services 5 kilometers outside of Mysore. So we can't hire physicians or nurses to do rural health. We had huge problem with trust. Rural communities did not want to trust us. Sure enough, because our previous governments had rolled out this mass sterilization programs in these communities for population control. So they were not willing to trust anybody from outside when we came to say, we're going to do good for you. We're like, it's good for you, not for us. So they did not trust us. And we also had this challenge because the government had just rolled out this National Rural Health Mission program. There was a lot of distortion of the data that were coming out because the government wanted to show that it was doing a good job. So they were saying, take this program. All our deliveries are institutional. So we had to think of how do we change this? Because I had 3 years and Elizabeth Glazier, the foundation had given me a shitload of money and I had to show them results. So we had to think on the fleet. What do we do? So we had a complete paradigm change. What we did was forget Western medicine doctors. What we want for these people to do is follow the algorithms we are setting up. So we had one allopathic doctor, but we hired doctors who had training in Ayurveda. And Ayurvedic doctors have the same first 2.5 years training as Western medicine. They do the same anatomy, biochemistry, physiology, microbiology, everything is the same. The thing that changes is they use a different set of drugs versus allopathy would use a different set of. But otherwise, the basic training is almost the same. So we said, okay, we're going to get an Ayurvedic doctor. So Dr. Bhavna, she joined us. And she worked under our MD, who was the OBGYN. And we had algorithms, and she would follow whatever we told her. We also, like I said, we had to get permission from all the gatekeepers, right? So when we spoke to the district health officer, he said, we don't need your program. Less than 10% of the deliveries are happening at home. You're wasting your time. Then we go and talk to the sub-district medical officer, and they say, we need your help because we're trying to get more women to come into the hospital. Now, who do we believe? Right? So we had to figure it out for ourselves. So what we did is we decided we were going to go and do a survey ourselves. So we did a probability proportionate to size sampling of the 144 villages, and then we went and did a door-to-door survey. We took 10% of the villages, about 16 villages. We enumerated every single household to find out how many children below 6 years of age and where were they born. We wanted to know ourselves. And we have a lot of students who come and work with us all the time. So we always welcome students so that they get to learn how to do community-based research and rural health. We had to track that person because this was a random sample. So we had to get that person. So wherever they were, we would go. This is a laundry happening right there. That's a woman washing the clothes. That blue thing is a soap bar. And she was washing the clothes. We had to track her down, and we tracked her down, and we were asking questions. We also had to make sure, because most villages don't have house numbers or addresses, street names, so we had to make sure we were not going back to the same houses. But we cannot touch the house because we had some major issues during polio eradication when houses were being marked. So we had one of the kids from the village mark the house. If we had finished the survey in that house got marked. So we don't go back because we were a big group of people trying to get these things done really fast. So what did we find? We surveyed about 1,000 households. We had 94% response. 19% was the median, 19 years was the median age of the first delivery. Sure enough, 40% were home deliveries. We had our data. And the deliveries were assisted among those who happened in the hospital, 62% were being done by the doctors or nurses, 31% were by traditional birth attendants, about the rest were by relatives or their neighbors. When we did the multivariable analysis, the factors that were independently associated with receiving antenatal care was institutional delivery. If you were going to deliver in a hospital, sure enough, they were getting antenatal care. And if they were of a higher socioeconomic status. The factors that were independently associated with not getting antenatal care was belonging to a lower caste or having below poverty level card. So if you have that, you get services. And a lot of people who are poor don't have that card. And if you don't have that card, you don't get subsidized services. That was associated with not getting antenatal care. And of course, if you were already planning on having a home delivery, you were not going to go to the hospital, so you were not going to get antenatal. So we concluded that a substantial proportion of women were delivering at home and were less likely to receive antenatal care, which means they were not going to get HIV care services as well. And traditional birth attendants were performing home deliveries, and we have to some way figure out how to integrate this with them. All of this is published. So we also had, I told you, our second problem was trust in the community. So we had to make sure that we started to build trust. So we would go and provide care for other things that they want. Our agenda was antenatal care, but that doesn't mean you can ignore the men, you can ignore the older people, the children. So we would go and do free clinics for them in these communities so that they knew that we were not coming here with an agenda. And we also started talking to the traditional birth attendants and providing them with birthing kits. Because if by chance they are going to have home deliveries in these communities, at least let us try to have them be safe. Not that we were encouraging home deliveries, but if they happen, let's try to make sure that they are safe. So we were showing these women all the things that we had in the birthing kits so that they would use them. We also wanted to understand what are the practices? Why is it that when it's a traditional birth attendance, we have these issues? And who are these women? So we wanted to understand. So it was really challenging. We had to identify all the traditional birth attendants in 156 villages. That was our catchment area. And this was around the time the National Rural Health Mission had started. And they had told people, if anybody assists a pregnant woman in the community, they will be imprisoned. So when we went in with our program, they thought we were investigators coming from the government side to come and find out who's helping so that we could take that messages back to the government. So nobody wanted to talk to us. They were like, we don't know. So it took a lot of spending time and building that trust with them. And what we wanted to know is who are these birth attendants? What are their practices and what do they know about HIV? And then we were giving away birthing kits to all these women who we were meeting wherever they were. And we were inviting them to a training on HIV. We thought we'll train them. Why not? We have this opportunity, we have the money. Sub-Saharan Africa, where there is a tradition of traditional birth attendants who are respected in the community, they have a role. So you can actually work with traditional birth attendants in Sub-Saharan Africa, which you cannot do in India. And these are basically women who may have delivered their daughter-in-law or their neighbor. Essentially, it's just come out of practice of whatever they will do. Otherwise, they are like working in the fields, right? We have to go track them in the fields. They are farm workers. They are not like professionals. They just happen to deliver babies. That's it. So here was Rani, our nurse. So this lady was telling us where we had to go to find that birth attendant, and we had to go through those fields with snakes in it to go and track this woman down. And Rani was a brave woman. She went and she tracked them down. She tracked her down. And that's Paul. Now he is a internal medicine fellow at UCLA. He was a little boy when he came to me. And Paul is holding the birthing kits to give it to her. But what was really interesting is these women had never seen a glove in their life. Forget about using a glove. They've never seen a glove. And then you're trying to tell them, okay, you're going to use a glove, you're going to use a blade, you're going to use this thread, you're going to put this sheet. It was like French to them. They're like, what the hell are you talking? Look at this woman. She was fascinated. When we tried to put a glove on her hand, she's like, what is this? You know? So we were able to find 400 and odd birth attendants. The average age was 53 years. Most of them had no education. And most of them were Hindus. In the villages, most of them are usually Hindus. And we have published on this as well. Why is it not moving? Ah, the animation is not wrong. Essentially, what it says behind is they had zero knowledge about HIV. And we had like about 12% had heard about HIV on television, but even they were talking about HIV being transmitted by mosquitoes, eating in the plates, and all of that stuff. And their birthing practices were scary to even talk about. If you guys want some fun reading, this is a great paper to entertain yourself. So we figured at that point also because these women were 77% had no education, and they were already like when we would talk to them, they would fall asleep when we continue to talk for more than 2 minutes on anything about medicine. So we knew that they were untrainable. We couldn't train. So what's our next step? So we decided we're going to partner with the National Rural Health Mission folks. National Rural Health Mission had decided they were going to have one woman in every village who's called an ASHA worker, community health worker. Eighth grade pass, but she would be like the liaison between the government health system and the villages. So we decided, okay, let's talk to these women and see what we can do with them. So we started to build bridges with the National Rural Health Mission. And for every 5 villages, we have one auxiliary nurse midwife, one midwife. But this midwife runs that clinic. She is in charge of immunization. She is in charge of chronic disease surveillance. She is in charge of everything in the kitchen sink. Does she have time for deliveries? So we got all the auxiliary nurse midwives as well to come, and we trained them on what we thought they needed to know. So we started to have linkages. And these were those ASHA workers, the community health workers. We gave them a status. We said, you're important. You are our eyes and ears in the community. We want you to be part of our group. We want you to help us. Then was when we started to do what we had to do. We did a lot of medical clinics for free. And I mean, look, they give us a place like that. That was our clinic for the day. Had whatever they could space. We would take everything we needed for clinics wherever they called us in the communities, and we would go set up shop. And we would provide healthcare, free healthcare. We had to continuously engage the communities. And in a lot of these communities, although we are doing maternal child health and women's health, you cannot ignore the men. Men are your biggest allies. We have to integrate men into the programs. We have to emphasize the importance of men in some of these decision-making processes. So we would engage all of them, children, old, young, everybody, because we wanted to have an open agenda. Everybody know what we're doing. And we would triangulate our data with the public health programs. How many pregnant women did we find? How many did the government find? And if they had lesser number, we would share data with them. And that's what we were doing here. So preparing the community, then we would let them know we are coming. We're coming with a clinic to your village. So we would put out flyers everywhere. This is Satya putting up the flyer saying tomorrow there's going to be a clinic, and that's the common water source for the entire village. So all the women come. So strategically, we would have information put out. And then the first day would be education and awareness. We weren't doing didactic lectures. These guys don't give a shit. What do you know? You had to engage them at their level. We love song and dance and drama. So we would use role plays. We would come up with stories. So this is supposed to be a doctor, and that's the husband bringing his wife with his mother to come and see, and why is it important to get antenatal care? So we would put out stories, and we would use a lot of humor. Humor is the way we connected with our communities. And you can see again, we used to have full houses. People are interested. Men showed up as well because they wanted to know what was happening. And then we would do this. And for us, we also had an evaluation component. We wanted to know whether really what we were talking, did it matter? So we would do, who wants to be a millionaire? We would ask questions. And if they answered correctly, we would have a little prize for the women. And that's how we figured out what knowledge was being transmitted and what they did not know. So the next time we would work a little bit more on. And the next day, we would have it. We would take everything we need in a bus to wherever this place was. And chairs, tables, garbage bins, everything. That was us loading up to go to a village. And then we would set up shop. Where would we set up shop? I showed you. If I set up this side, these guys won't come. If I set up this side, these guys won't come. Where can we go? A school. Everybody was for school. So we would negotiate with the principals and the school leadership there to say, give us one classroom and that corridor place for us. That's the school corridor. And that room is where our doctors are seeing the patients. Women would show up from the village. They all showed up. Here, Savita was registering all the pregnant women, and they were lining up to be seen. And before they get seen by the doctor, they have one more round of counseling with our counselors, explaining exactly what we were going to do to them and what is expected for them. And then they would go in and they would be seen by a doctor. And again, we have issues of religion, right? So this was a Hindu doctor, Dr. Vijaya. This was Dr. Shaheen, who was a Muslim. We had to make sure that we were connecting with the communities at their level with what they want. We would do the blood draw right there. We would run the examples of all the basic processing. This was blood grouping, and all of that was being done right there, and everything else that we needed to do other advanced diagnostics. We would have all the bloods. We would bring it back to our clinic, run the test, go back, and share the results. And then we would follow these women post-delivery because we wanted to know that they were still alive. We couldn't do the deliveries because the government was very strict that they were going to take care of it. So we did not want to step on each other's toes. So we were doing everything around them. So we would go and make sure that we were talking to these pregnant women, checking on their baby, checking on them, seeing if they were okay. So we followed them for up to 2 years. So these are all our beautiful babies. Now they're all teenage kids, and we're doing mental health studies with these kids now. How cool is that? And now I'm a lot grayer than I was then. So yeah, we were able to get about 1,600 pregnant women for that particular mobile clinic. Of the 1,600, we had 98% accept HIV services. And we had trained 463 community health workers. And we had done 141 programs, education programs, reaching over 5,000 community members, with about 900 being men. And we had found 14 HIV infected moms who would have otherwise missed getting medications if we had not found them. So now we had to add another angle to it. We said, how about we up the ante now? So with the Positive Action for Children's Fund, the next 3 years, we added 2 other components to it, a development component and a community mobilization component. And here it was, again, reducing vertical transmission by adding these 2 components to it. So here, what we did was we worked with the largest grassroots organizations in the country. They call the women's self-help groups. They're groups of 10 women who get together and they donate into the pot a small amount of money every month. And one woman takes that pot to either start a business or clear her loans or whatever for her family. So we have extensive self-help group networks around the country. So we started working with the women's self-help groups. We said, okay, if you help us in following this one pregnant woman from the start to the finish, we will give you money. That money will stay in your group, not one individual. And the advantage for the pregnant woman is she'll have 10 women who's going to support her, not one. So that was the model we used. We had fantastic results. This is the self-help group getting the money after they had gotten the result. That's another group. Look at how happy they are to get that green. Happy women. Our pregnant women are safe. They're getting the money from the government. And these women were getting money from us. And that money was staying in the group. Happy women. Oh, I love it. I love these pictures. That's why I love to show pictures. And we compared the 2 models. The skill without the community mobilization and the economic model versus it. Forget reading all that. We had 67% more pregnant women receiving antenatal care and child testing. And we have all this published, so I'm not going into the results. I wanted to show you the process. And all of what I've talked is not my work. I'm just taking credit for it. I have an awesome group of colleagues who do this amazing backbreaking work. And the group I really work, it's all run by women, these rock star women. And we only have 3 men. They're all sitting down there. They listen to those women. So this is the group that I work with. I almost think they're my family now. So yeah, so this is what we did to work on our maternal child health program. We've used the same model now to do cervical cancer screening program, and they're working just as well. So I will stop there. Thank you for your time. I'm happy to take it.